Okay, I think we're ready to get started this evening. Can everyone hear me? Yes. Great, okay. My name is Debbie Nuss, and I am the current chair of the Flint Hills Wellness Coalition, and I want to welcome all of you to our public forum on healthcare in Riley County. Thought I'd tell you a little bit about the Flint Hills Wellness Coalition. The Flint Hills Wellness Coalition works cooperatively with citizens and groups throughout the city of Manhattan and Riley County to develop community norms that support healthy behaviors and environments. Our mission is to create a healthy, equitable community for our residents through policy, system, environmental, and personal change. The coalition has been successful in improving access to healthy foods, reducing exposure to tobacco in public parks, and advocating for bicycle pedestrian-friendly environments. We have been working diligently to address the needs identified in the 2015 Community Needs Assessment through 4 work groups. One focused on nutrition, one on active transportation, one on mental health, and another on access and coordination of services. And we've also been working to address health equity issues, specifically in Northview, as a model that we hope to replicate throughout Riley County. Finally, the coalition is coordinating the 2020 Community Needs Assessment for Riley County that will be upcoming in the next several months. We're doing this in partnership with many of the agencies who have representatives on the panel this evening. So why are we here tonight? At our monthly Flint Hills Wellness Coalition meetings, we discuss issues of community concern aside from those being addressed in our work groups. Over the course of the past year, concerns regarding the quality of our healthcare system and access to services in Manhattan-Riley County have consistently been raised by those in attendance, either based on their own personal experiences or anecdotally from others. So rather than draw conclusions solely on what we were hearing, the Wellness Coalition thought it might be beneficial if we held a community forum to initiate a discussion in the community. So we invited the people that you're going to see here on the panel this evening as a beginning conversation about whether healthcare in Riley County is at the crossroads. The coalition also recognizes that there are other areas of healthcare not represented on our panel this evening, but if we had tried to represent all aspects of healthcare, we could have been here for days, I think, because of just the number of people that would be on the panel. So again, this was a start, and we hope to do other forums to continue the discussion. So first of all, I want to thank all of you for coming this evening and for your interest. For those of you that don't know, we are Facebook Living this, so if you know of people that couldn't attend tonight and have access to Facebook, they'll be able to watch it later. And I was getting text messages and private messages asking me if it's going to be in TV, so people are interested, they just couldn't get here. So I wanted to talk to you just a little bit about the format we're going to follow this evening. After I conclude my comments, I'm going to introduce Jennifer Green, who is the administrator at the Riley County Health Department, and she's going to share some data with us regarding healthcare and access to healthcare services in Manhattan-Riley County. We hope that this data will help set the stage for your questions as audience members, as well as the responses that we hear from the panel. Then after Jennifer's presentation, panel members will be asked to respond to 2 questions prepared by the Wellness Coalition. Panel members will each have 2 minutes to respond to each of those questions. And while panel members are responding to the Coalition's questions, we'd ask you as audience members to write down questions on cards and then submit them to volunteers that will be circulating around the room. And then they will take those cards and sort them. We anticipate that there'll be some similar questions, so we'll sort them, and then they will be passed to me as the moderator, and then the questions will be posed to the panel. Panel members will have 1.5 minutes to respond to audience member questions. Given the amount of time that we have the rooms this evening, we think that we should be able to ask at a minimum of 6 questions. And then after those 6 questions are answered, panel members will have 2 minutes for closing remarks. We are going to give panel members the opportunity to respond to questions that aren't asked in writing. We will send them to them after the fact, and then hope that they will respond to them, and then we will post them on the Wellness Coalition website so that people can see the answers to questions that we don't have time to ask. So, given that, I'm going to introduce Jennifer Green, who is the administrator of the Riley County Health Department.
Good evening, everyone. On your way in, you should have received a handout that looks like this. It is a version of our county health rankings. So each year, the Robert Wood Johnson Foundation puts together county health rankings for nearly every county in the country. And we have our Kansas Health Institute here in the state that provides a little bit, puts these fact sheets together for you in the community. And so this will provide some context and a much deeper dive than the 8 minutes or so that I have allotted tonight. If you look towards the middle of your page, you'll see a green line that says clinical care rank. So that's where quite a bit of our data is coming from tonight, although not all of it's going to come from there. But if you have questions about the data or what we're going to dig into tonight, I'm happy to answer those questions. So here you see the mission statements of the Health Department and the Flint Hills Wellness Coalition. Just a word about the data. I told you about the county health rankings. These are our data from 2019, although the actual data might come from a different year, 2016, 2017. We're also going to look at briefly our community needs assessment, our community health improvement plan, some Kansas Health Matters data, and then Jared with the Flint Hills Metropolitan Planning Organization was nice enough to share some data from Adibus with us. And then you'll also hear me reference HRSA, which is the Human Resources and Services Administration. So to kick it off, Debbie mentioned our community needs assessment. So overall, our community is one that has many assets. We have a high quality of life here. It features lots of amenities and high prosperity. But on the other hand, we have dwindling resources for those, dwindling resources for some, and a lack of attention to those who are most in need in life. As part of the needs assessment, key informant interviews were also conducted, and a few central themes from those came up. One, that we need a one-stop shop for all of our healthcare services, with a lack of access and affordability of resources, and a lack of access and affordability of culturally competent medical care. Debbie also briefly alluded to our 3 work groups that are part of our Flint Hills Wellness Coalition. Those are aligned with the 3 priorities in our community health improvement plan, which are access and coordination of services, transportation, and mental health. And all of those, I think we could agree in this room, are all about access to care. And you can find that report on the Flint Hills Wellness Coalition website, along with the community needs assessment. So if we look back at our community health rankings, one of the measures that we want to look at is about the percentage of our community members that have health insurance. So this is also what we reference as a Healthy People 2020 measure. So those are nationwide measures that we want to look at. And according to Healthy People 2020, we ideally would have none of our residents that are uninsured. We're not there yet. In Riley County, about 9% of our residents are uninsured. Compared to the United States, that's 6% of the United States and 10% of Kansas overall, residents in Kansas overall are uninsured. So we are getting better for this measure, but we are not there yet meeting our Healthy People 2020 target. Another measure that we like to look at are preventable hospital stays. So this is the number of ambulatory care sensitive conditions. We can dig into that after the form, what that means, per Medicaid enrollees. So this is a measure where we are getting better, but we are not quite there yet. There's no national measure to compare us there yet. So I'll note that Riley County is there at the top, 232,356 preventable hospital care stays per 100,000 Medicare enrollees. So that number is declining. Riley County is there in red. So for all of these charts, Riley County is there in red, and you can see that we're going down, so that is good. Fewer preventable hospital stays. I will note, if we looked at the data even closer, there are wide disparities by race and ethnicity if you look at that measure. Another measure we want to look at is about our health professional shortage areas. So we don't get into how that is configured today, but this is where we want to look at to see where do we need more providers in our community. Mental health care, primary care, and dental health are areas that our community is designated where we have shortages of those providers, and that might be because and it might be for particular geographic areas. So, for example, specifically northern Riley County or Ogden, or for low-income residents. So it kind of depends for each measure. Debbie mentioned access to mental health care. That's something that came up in the needs assessment. This is an area we have a professional shortage for. The top three measures noted on the needs assessment were about affordable mental health care services, affordable services for those that don't have health insurance, and making sure that insurance covers mental health care, and that we have high quality services here. We did a little CHIP survey and collected some supplemental data, and 64% of our residents said yes or maybe they would use a mental health crisis stabilization center. As many of you in the room may know, Pawnee Mental Health is working on that and is set to open later this year. So that piece of data says to me that that is well invested, or those dollars are well invested, because that's something that our community members have said they needed. If you look at access to primary care providers, we're again here in red. So this looks at the percentage, the number of primary care physicians we have per our population. So for every one resident, for every 1,500 or so residents, we have one primary care provider in our community. That is a little bit comparable to the US and Kansas. And then I want to show our Riley County healthcare provider map. Every dot is a healthcare provider, not necessarily a primary care provider. It might be a long-term care facility, it might be EMS, it might be an orthopedic or a dentist, but each dot you see on the map is a healthcare provider. So this looks at Riley County, and if you look at the bottom of the map, you can see there are some census tracts that don't have primary care providers, and it's really centered in the middle of Manhattan. If we looked over to the left of our map, we'd see Ogden, and there aren't any healthcare providers, or very few healthcare providers in Ogden, I'll say. And this is our map of northern Riley County. So there are two dots there, and those are both long-term care facilities. So we have and affiliated with nursing homes, so fewer in northern Riley County too. So we don't want to forget about our friends in Ogden and Riley and Leonardville. And then I will talk just briefly about our staff hospital bed ratio, so that's also on your chart here. That's the average number of beds that are staffed during the year. So 1.5 beds per 1,000 members of our community, and this number is trending downward, which is good in this instance. So we want more bed. So that's a good thing for this particular measure. And then Debbie finally mentioned transportation, and I'll kind of wrap it here. But transportation in our community is really related to access, and that's something that we hear over and over again. So the top needs that we heard on the needs assessment related to transportation were improving our public transportation and developing a pedestrian-friendly transportation system. As it relates to healthcare, the Flint Hills Metropolitan Planning Organization pulled together some data, and now in our community, 100% of our medical services are covered by the out-of-bus route. So that means they're within a 5-minute walk of every medical facility that's in our community, where the out-of-bus goes. So perhaps not in northern Riley County. And there is, as many of you know, about a year ago we got new bus routes, and 154% increase in ridership since we started those new bus routes. Emergency services, this is a picture of our whole community. You can see it's centered in Manhattan with our hospital and EMS, but there are outlying offices out in Riley, Randolph, Leonardville, and if we look to the left a little bit, in Ogden as well. So I will end there, just as with a reminder that our Flint Hills Wellness Coalition meetings are the second Tuesday of each month at the health department, and you're more than welcome to come. They're open, and please visit the Flint Hills Wellness Coalition website. And I will turn it back over to Debbie.
Thank you, Jennifer. That was a lot of good information, and information that, at least in this community, we seem to track very, very regularly and utilize it quite often. I'm now going to invite our panel members to come forward and take their seats at the table. As they're walking up, I'll just say their names. Bob Koppel, CEO of Ascension via Christi Hospital. Dr. Deb Doback, who is currently the president of the Riley County Medical Society and is with Stone Creek Family Physicians. Josh Gehring, the assistant director of Riley County Emergency Medical Services. Bruce Johnson, the crisis stabilization manager at Pawnee Mental Health Services. Tracy O'Rourke, senior vice president and chief administrative officer at Stormont Vail Health. And then Chris Stipe, who is the CEO of Manhattan Surgical Hospital. So again, thank you all very much for coming this evening. I know you're all busy people, and finding a date that worked for all of you, thankfully was not a challenge. So thank you, and thank you for making the adjustment when we had to change. We very much appreciate it. So as I mentioned earlier, we're starting out with two questions that our Flint Hills Wellness Coalition generated questions. These questions were sent to the panel members in advance. So, and we're going to start with Mr. Koppel answering first, and he'll have 2 minutes. And so the question that they were asked, the first question is, what is your agency's capacity to meet the healthcare needs of the community? When you think about your response, don't limit it to clinical services. Think about it in terms of, for example, how the health of individuals impacts the health of the community, the number of uninsured or underinsured, our community's changing demographics, our poverty rate, and or whether we have adequate specialized services. So, Mr. Koppel.
So we're going to nail that in 2 minutes. So one, thank you for the opportunity to be here this evening. So when we think about, I guess, capacity, for me it drops into 2 or 3 different buckets. One would be the areas we have challenges in, the other is where we actually are seeing successes, and then just how does this impact some of what we would see as the key community health needs as part of our own community health needs assessment that we're required to do. So from a challenge perspective, workforce, I think, would be on the minds of every organization in town. Ascension via Christi is no different. And that really is twofold. One is just available associates or staff. And I think the importance of specific niche training and knowledge of specific modalities. The very generic thing we always think about is, do we have enough nurses? And that's definitely a big issue. We employ over 200 nurses. So that's a huge chunk of our workforce. But it is just as vitally important that we have respiratory therapists on that shift, and that we have lab techs, and that we have folks who work in imaging who can do ultrasound versus vascular ultrasound. And so, I think that's some of the challenges. Provider, the number and ability and just the breadth of scope of our providers in the community, quite honestly, I see that as another challenge. We've had success with primary care recruitment in the community. And you'll see that ratio change when we come to 2019 data and 2020 data. And it's actually accommodating even for the retirements that we've already had this year, the retirements that are going to still happen this year, and the retirements we already know about next year. And so as a community, and it's a bunch of different groups and practices, because Manhattan is primarily an independent physician community. And so when we talk about primary care, they're actually spread across 7 or 8 different groups. And so but we've actually seen success, a bunch of success, and I think I'm out of time, but I think some of my compadres can probably speak to that a little in more detail. The concern would be the specialists, especially medical specialists. And that is where, again, we have retirements and people who have left the community, and our ability to replace them in our environment, that is a challenge, I think. And that's a capacity limiting challenge.
Thank you, Mr. Koppel. So Dr. Doback, and Dr. Doback gets to represent all physicians in town. She's going to respond to this question. No, she understood how she was going to respond to that.
So the Kansas Medical Society, the Riley County Medical Society is under the umbrella of the Kansas Medical Society. First of all, I'm Deb Dobeck. I'm a primary care physician. I've been living in Manhattan for 27 years. And the mission statement of the Kansas Medical Society is to unite the medical profession of the state of Kansas in promoting the science and art of medicine and protecting the health of the citizens of the state. There are around 6,000 physicians of all specialties that practice in the state of Kansas. There are 110 active members of the Riley County Medical Society in Riley County under that umbrella. So I want to address the primary care physicians in town, and I am going to be looking for a hands up. How many people in this room have gone to or heard of Dr. Chance Williams? Raise your hand. Raise them high. Raise them high. He is a new primary care physician. That's great. There's about half in the room. Now, I might say you can't raise your hand if you're a medical provider. I'm seeing Dr. Lehman in our ED. I'm seeing Karen at the K-Stat clinic. Let's say if you're not a medical provider. He's a new primary care physician. How many people who aren't in the medical world have heard of Dr. Nick Cahoy? Raise your hand. Okay, there's 2 or 3. He's a new primary care physician. Dr. Vanessa Cook, raise your hand. I see 2. Dr. Lon Lee, raise your hand. I see 2. Dr. Nugent, I see 2 or 3. Dr. Steve Schamberg, raise your hand. I see 1 up. Dr. Danelle Perry, raise your hand. Nope, no hands. That there are 7 new primary care physicians who've come to Manhattan in the last 2 years, and there's 2 more coming. Dr. Amy Cunningham is starting this month, and Dr. Jason Hoke is starting in August. So right there, I just listed 9. I agree with Mr. Koppel. We seem to be getting that base covered. We are going to be hurting for specialty care when if you retire, and I'm going to mention those. Neurology would be one. We are always short on psychiatry. We could always use more psychiatrists. I want to put a plug in for Pawnee Mental Health. They do a great job with 1 psychiatrist, Dr. Lassie, and many mid-levels under her.
Okay, Dr. Dobeck, your 2 minutes is up. Okay, so thank you. So Josh Garrett with Riley County Emergency Medical Services.
Good evening. My name is Josh Gehring, again with Riley County EMS. I want to thank you all for being here tonight. And thank you all for sitting up here with me.
You might want to pull your microphone
A
closer.
little closer?
Yeah.
Or tilted.
Tilted?
Yeah.
There we go. So when I think of Riley County EMS's capacity to be responsive to the needs of Riley County, what I think of first and foremost is patient advocacy. One of the unique functions of EMS is that we are strategically positioned to not only observe and feel the changing trends in a community's overall wellness, but also to respond to them. By definition, we are, as individuals, first responders, which traditionally means we're the first on scene. In a less literal sense, what that means is I do believe we're the first to kind of feel certain specific changes in trends in a community's overall wellness. So as far as our capacity to address those changes, I think it's primarily in our ability to advocate for you all, and to walk into your homes, take that sacred duty and that sacred invite seriously, and then advocate for your overall wellness and through the continuity of care.
Thank you. Bruce.
Great. I'm Bruce Johnson with Pawnee Mental Health, and the fact that I'm even able to be here today or invited to be here today means that the community has changed over the past 10, 20 years in recognizing that mental health is an important aspect of overall well-being. In 2013, actually mental health care for mental health services surpassed heart conditions as the #1 most costly specific disorder. And we also know now, and it's more and more apparent, 1 in 4 people at some point in their life are going to experience a serious mental illness. That means that for the front row and then half of the second row, you guys are going to probably have a rough time at some point in your life, just saying, okay? So it's pretty significant, and that's come to the forefront, and that's been a really big help in us delivering mental health care to the community, is just that change in attitude and openness. And what we've seen at Pawnee Mental Health, a lot of challenges that we're faced with here in the community, we're actually running into capacity issues, physical capacity, the ability to be able to provide the services that we need to provide. We've talked a little bit about attracting providers and those sorts of issues. We have those problems as well. It's a difficult challenge. The state of Kansas has a difficult licensing where we can't really bring in people very easily from other states to provide mental health services. Those licenses don't automatically transfer over. There's a lot of hoops. So we lose a lot of potential options for people coming in. And then the other piece that we've reorganized all of Manhattan actually and Riley County to be able to accommodate as many services as we possibly can, but we're bumping up against the edge there of the next couple of years of where we're going to probably need to look at something a little bit more and be smarter about what we're doing is what we've started doing now. And that's where one of these services, a crisis stabilization service, comes in as well. We can talk about that a little bit later.
Okay, thank you, Bruce.
Thank you.
Tracy O'Rourke.
Yeah, so 2 minutes goes by fast. Until somebody's in front of me. Well, good evening. Can you hear me? No, bring it up a little bit more. Well, good evening. Thank you for letting us be here. Tracy O'Rourke, I'm with Stormont Vail Health, and appreciate the opportunity to be with you all tonight. Actually, I'll give a lot of credit. We have a number of our providers, our continuity providers here in our audience, and they're the ones who are doing the day-to-day work, helping the patients here in Riley County and the area. Stormont Vail has been here for a number of years with our cotton and meal practice. We have 20 providers that cover both primary care, cardiology, neurology, and we rotate a number of different specialties through here, including some of our pediatric specialists, our additional cardiology coverage, some of our additional needs like neurospine, neurosurgery, and orthopedics. And our goal is really to listen to the community and understand what are the needs. We've done our own analysis for recruitment. We're bringing in additional primary care this year, as well as looking at more specialists that will kind of round out and complement our current team. The other thing is capacity, and space is always a concern, but that is one of the other areas that we look at and are looking at for this community, because we feel like because it's growing at such a rapid rate, 5% I believe over the next few years, year over year, that's significant. We need to be able to grow too and serve the community better. So we are looking to expand our footprint and be able to add some additional resources and services that will make sense for Riley County. You know, Stormont has also served this community as part of our hospital based in Topeka. Actually, about 20% of inpatient services are provided at Stormont. We're a level 2 trauma center. We work with via Christi. Our emergency physicians serve that emergency room. And we've appreciated that relationship for a number of years and continue to want to grow and make sure that it's a very seamless when there is a need to transfer. You know, we also look at the community health and the community needs, and we have been actively evaluating where we can support more actively this community and your community health needs. We do a lot in Shawnee County. We want to do more here in Riley. And over the next few years, we continue to invest. We'll look at those opportunities along with you guys.
Perfect, thank you.
Yep.
Chris.
Can you guys hear me? Okay. You know, that part of that question, the healthcare needs of the community, how do you meet the healthcare needs of the community? And I think the first thing is our organization is a majority physician-owned organization and has been in existence for 18, 19 years in Manhattan. And, you know, I think the first thing you need to do is deliver care. For the areas that you choose to deliver care for patients, I think healthcare in particular, you should be compelled to be delivering at the highest level, okay? So I I think if you're going to meet the needs of the community and you choose to deliver healthcare, that delivering it at the absolute highest level, getting better at what you do every day is so important. And Manhattan Surgical Hospital does that. And we're ranked as a 5-star hospital in the state of Kansas. There's only 8 hospitals in the state of Kansas that are ranked as 5-star facilities. That's based on your patient satisfaction, clinical outcomes, those types of things. And we can talk more about that if anyone would like to. But we've also been recognized by U.S. News and World Report as a high-performing hospital. So those are some of the things I think that you should be compelled to really, if you're going to deliver health care, do it right, do it at the highest level, meet and exceed the standards of care and meet and exceed the expectations of your patients and their families. And, I think that's something that we do. And, actually Manhattan Surgical Hospital is 3 organizations. So we're the main hospital. And, we specialize in outpatient, inpatient surgical care, endoscopy, and pain management services. But we also, in 2017, we purchased the Central Kansas Cancer Center, which is a radiation oncology therapy center. And we deliver CT services there as well for those patients and for outpatients. And then primary care, we talked about. Our board and our organization recognized the need for primary care physicians. We opened Blue River Family Medicine in 2018, and we moved into a brand new facility just recently on the east side of Manhattan, which is a $3 to $5 million investment, depending on how you look at it, in the community. So new physicians, we have Dr. Schamberg and Dr. Graves and Myra Wilson, who's a PA. And then we have Dr. Del Rey, who's going to start with us in August. So, we're doing what we can to attack some of these needs, and in particular, primary care, is something that we've all talked about. So, I think it's gotten a lot better over the last several years. Hopefully, you guys have noticed that. So,
Okay. Thank you, Chris. Okay, before I ask the second question, and we will start with Dr. Doback, I want to remind you that if you have questions that you want to send on cards, Tanya and Jennifer, you want to circulate too, and while you're answering while the panel's answering the second question, they will be going through the audience member questions, and then we'll start to go through those. So the second question that the Wellness Coalition posed to the panel members was based on your own response and the response that you heard from the other members of the panel. What should or can be done to address the community's healthcare needs? So you've told us what you're doing. And you've told us a little bit about some of the things that are being done. But what can or should be done to? We could even talk about maybe the unmet health needs of the community. You can think about it in those terms too. But frame it the way you want. So, Dan, 2 minutes. 2 minutes again. Yeah.
I'll stay within my 2 minutes this time. You won't have to cut me off. I'm going to talk about 2 things. I'm going to talk about what should happen, and that is our Kansas legislators passing Medicaid expansion. Our 3 legislators get it. Tom Hawk, Sidney Carlin, Tom Phillips. Full disclosure, I'm married to Tom Phillips. Get it. They voted for Medicaid expansion. What we need to do is get out in the other areas of the state and help their districts vote in senators and state legislators, because our legislators get it. From January of 2014 till this week, the federal dollars that could have been given to us, to Kansas, is $3.3 billion that have gone out our windows to other states for their underserved people at low income. So that's one thing. Number 2, I would like our Riley County to utilize our Flint Hills Community Clinic And I'm going to have Susan Inskeep stand up. I had her come tonight. Susan is the director of our Flint Hills Community Clinic, and her clinic on 4th in Houston takes care of our most vulnerable people who have no health insurance. Please talk to her after this if you don't know about that clinic. And I'm going to pass.
Got one. Can everybody hear me a little bit better this time? Maybe? All right. So in my first comment, I said that EMS is strategically positioned to feel and observe and be responsive to the kind of evolving and changing trends in a community's overall wellness. One of those trends that we've recently observed is since 2017, we've seen roughly a 30% increase in our response to behavioral or mental health type emergencies. These are callers whose only acute threat to their wellness is their own mental status, their own current disposition. And that's a shocking number for us, and that's quite an increase. And unfortunately, that's not something that historically paramedics are very well prepared to be responsive to. So what we've done, we've put all of our line officers through a mental health first aid certificate program. What we plan to do is to partner with the Riley County PD Crisis Intervention Team and the Riley County Crisis Intervention Task Force to begin putting all of our department staff through a pretty intensive crisis intervention training, which just allows them to better respond to, identify, and address people that are in crisis. Unfortunately, EMS is kind of a new industry, but there were times when, as an industry, these people were labeled as frequent flyers, right? And quite literally, they were just pawned off on someone else, right? In the truck and to the hospital. And I think at Riley County EMS, we're not satisfied with that piece of the puzzle. So we're working diligently to learn and to grow and to be a part of the solution to that trend that we've observed.
Hey, Bruce.
Great, kind of piggybacking off of that, thank you.
Yes.
Yeah, I appreciate that. As far as the mental health services go, being smarter with what we do is what we need. We can argue all day long about we need more tax dollars, we need more this and more this and more, all sorts of things, and that'll never change. We always do. But we have to be smarter about what we're doing. A couple of things that we've done here in Riley County is we've added what we call co-responders, which are mental health professionals that actually work with law enforcement out in the field and respond to calls. And what that does, it tries to resolve that issue out there in the field right then and there, instead of, like you said, bringing them off and taking them to an emergency room and clogging up the emergency room with people that's not where they need to be anyway. So we have the co-responder program, and we're also helping support the crisis intervention training program as well. The other smart thing that we've decided to do is we've started with the Crisis Stabilization Center, which is currently under construction. It's over off of Hayes Drive. What the Crisis Stabilization Center is, and they have a few of these throughout the state, it's a place where local community people, right there in the community, if they're in a mental health crisis, they can actually go there and they can be treated for several days, up to 10 days or so, if they needed to, in that location, at a lot more cost effective than right now taking an ambulance ride to the emergency room, spending 8 hours to a couple days sitting in a gurney, and then being transferred off to Kansas City for someplace that costs a whole lot more. The smart thing about that as well, besides doing the right thing in the right place here in the community and providing compassionate care, is dollar for dollar. For every dollar spent in crisis stabilization, it saves $2 in the community. That's out there with the everything from law enforcement, keeping people out of jails, reducing ambulance rides, emergency room and unnecessary medical services. Unfortunately, right now, only about 23% of that population that we see actually has any type of payer source or funding for that service. So it's essential that we continue to maintain tax dollars and such to be able to support that, because it pays off double fold to the community.
Thank you, Bruce. Tracy?
Yes, I agree with most of the panel said already. I think it comes down to, we look at a lot of different factors and things that can be improved. One is what do we do with our current clinic and operations and ensure that there is access for patients and we have the services available and look at more of a team-based approach. But access is just one aspect of health, and health is actually only about 20% is about the healthcare services that you receive. The other 20% is your genetics and just the way you're made. The other 60% is determined by social factors, where you live, your zip code, the things you have access to in terms of healthy foods, safe housing, those aspects that if you think about how you shift community health and what we can be doing collectively, it has to take partnership and it has to be an effort that addresses those needs first. Food insecurity is probably one of the greatest drivers behind health and health outcomes. And part of our initiatives is to look at where we can have that intersect between healthy foods, food access, removing barriers to getting those access to that food, and then what does that do to ultimately improve the health and wellness of an individual. And then we can also address the clinical needs. But until we start to focus in those areas, it'll be very difficult for us to turn the dial on some of these other aspects that are happening within our communities at large.
Okay, thank you. Chris?
So the crisis stabilization that you're talking about, I've seen that work, so that's an absolute, I mean, I think that's a no-brainer to do that. In other communities, it absolutely does save money, and it's something that can have a huge impact on the community, so totally agree with that. I think we need to, I'm looking forward to the reassessment of the primary care problem to see if we really still have a problem. And then I kind of have a question about the cultural aspects of that. Some of the data that was presented talked about the cultural barriers to accessing primary care. So I'm curious as to what those things are, since many of us deliver those services. We need to understand that so we can better serve the community and make sure we break down those barriers, make sure we're offering the kind of services that the community is looking for, needs, and that sort of thing. But neither Tracy or I have mentioned the fact that our organization's announced a partnership, and we're working diligently to try to finish the legal aspects of that and start to get to work on some of the things we talked about in the community. And I think things that are, so you talk about what can we do or what are our organizations doing. Our board, our organization saw an opportunity to partner with a Kansas-based company, a company who's already invested deeply in Manhattan to take things to another level. And so that was an opportunity that our board saw, and we evaluated, and we chose to partner with Stormont Vail. And we really feel like that is going to bring resources, access to specialty care, help us grow our organization, but also help us serve Manhattan and its residents much better. So we're excited about that partnership and ready to move forward. So those are some of the things we're doing and as an organization. I'll turn it over to Bob.
As I think about, I guess we can sometimes look at all the things that are wrong, which is pretty easy because with healthcare usually we're treating somebody that there's something wrong. We tend to be reactive in that respect. I think it's just important too that we also pause, and if you'll notice on your sheet, one of the percentage indicators about the number of babies that are born in our community that have a low birth weight, and that's something that's improved. And a key piece of improving that was with our women's health unit and the local women's health group, making sure that women are not delivering before 39 weeks. And I think we're going on 5 years now since we've had an early elective delivery in this town. And so sometimes you have to get upstream a little bit, if you will, change some process, find ways to change how you're doing things, and then downstream you see that, so we now no longer have babies being born at a low birth rate who are then potentially have other health issues, might have learning disabilities, all this other thing that's going to show up in a classroom someday. So I think it's real important that we also just remember some of the good things like that certainly people are doing. The other reality is, we talk about poverty. The level of charity care that we are providing in our organization this year is running twice what the level was last year. And so we're on target for $14 or $15 million of charity care. And so that we look at that actually as an indicator of what's going on in the community. because it has to do about employment or underemployment or people not having access to insurance. To Dr. Dobek's point, the reason that the U.S. rate for people being insured is 6% and Kansas's is 10% is because we've not expanded Medicaid. I mean, it's you do X, you get Y. So I mean, I just think there's so many things we have to kind of step back. Some of it's legislative that has to be done. Some of it has to be advocacy work. You know, I think to Chris and I, both of our point, the fact that we've had such success in recruiting primary care, that will lead to other things. It's going to take a little while maybe to show up. It's a matter of getting people into the doctor now, because we're now going to have options, more options than we had 2 years ago. Quite honestly, it is. I mean, it's a difference, a change, positive change. So that's how we can then impact the outcomes down the road, whatever indicators might be on next year's report or your report 5 years from now.
Okay, thank you. Lots of good questions have come up here, so I'm trying to consider them based on what the panel members have said so far. So let's start with this one, and Josh, you will be the first to respond. As a provider that has witnessed several incidents of overt and covert discrimination from providers to patients, what is your organization doing to eliminate inherent biases held by employees to deliver optimal, safe patient care?
That's a good question. I think by definition, Riley County EMS is a public safety entity, and so when members of the public feel unsafe in our care, that's indicative of a problem. So our core values are compassion, professionalism, and integrity, and those are not just taglines in an email. Those are things that we take very seriously, and especially compassion. So I think that we're evolving, we're growing, we're learning to be more adaptive to those needs and those responsive to the marginalized and the vulnerable individuals of the community who feel unsafe, because again, it's our job.
Okay, thank you.
Mm-hmm.
Bruce, do you want to answer that question?
Sure. I see a couple challenges. I know that to be honest, we probably don't have a whole lot of diversity in our providers. There is some, but it starts right there, right there in the office with who you have, your providers and everybody else, your peers and your coworkers. It starts and grows from right there, and we just aren't able to attract people from other places to come in and be a part of things. So it's a challenge. It's an ongoing challenge.
Tracy, do you have any comment? Do you want me to read the question again?
Sure.
Okay. As a provider that has witnessed several incidents of overt and covert discrimination from providers to patients, what is your organization doing to eliminate inherent biases held by employees to deliver optimal, safe patient care?
I'd say that, Stormont Vail as a whole, you might want to pull your microphone just here. So we continue to, our values are focused very similarly on respect and embracing diversity and inclusion, and we do our part to train and educate and understand differences. A lot of the things that we're faced with that are changing, we incorporate that within our clinical practices and with our employees from orientation all the way through continued education. If we do encounter biases and issues, we do the interventions and we do the education that we need. And again, I think we do our best also to ensure that we have diversity in our staff, that we're representing the community at all levels. And while it's an ongoing challenge, you make a concerted effort to have that as part of your core values as an organization.
Thank you. Chris?
It's pretty simple. It's education and accountability and zero tolerance. I mean, there's no place for discrimination in healthcare. People come to us in need, in pain, wanting things to be better with their health, and worried about family members there's really no place for that in healthcare. So, I mean, I think, there should be, healthcare is a place where really everywhere should have zero tolerance, but, that's a difficult thing to achieve. But in healthcare, we really need to treat everyone with respect, and, we do that in our organizations. I know that everybody on the panel does what they can in their organizations to educate and hold people accountable. So I think zero tolerance is really the answer.
Bob, would you like to respond to that?
Sure. As Chris indicated, we have actually mandatory education in our organization for what's appropriate behaviors, et cetera. In the last year, again, this is just a sign of the changing times, required module for every employee about gender identity training. Because that's something, 5 years ago, that I didn't have a module for that. As Tracy indicated, if we have an associate who's not exhibiting the appropriate behaviors that are consistent with our values of reverence around how we treat people, we have a performance management process. If it's a member of our medical staff, the medical staff actually is self-governing, and they have a process, and the person sitting next to me is the person who's in charge of physician behavior issues. So, I mean, and I think it's important for people to understand that to Chris's point, there has to be accountability, and you have to have a process for that. And so in any hospital, actually, that's true of any hospital in our country, the employer has a process for the associates, the medical staff has a process for the providers. So.
Dr. Dobek.
I really don't have anything to add. I agree with everything that's been said.
Perfect. Okay, thank you. Okay, the next question, we will start with Bruce for this question. What is your organization doing to eliminate provider staff burnout so our community has access to functioning present providers and subsequently safer care? Example, providers leaving to take better positions elsewhere. So what are you doing for reward and retention, basically?
Right,
Yeah.
right. And that's an ongoing challenge for all of us, I would imagine. Like I said before, we could always imagine throwing more and more money at something. We can't do that. I don't know if other people can, but really, it's awareness. It's increasing self-awareness, working with people individually. It's creating a kind of a spirit of core between your coworkers, because when you go to work, for all of us, no matter what your job is, you go to work not because you want to go work for the boss. You go to work every day because you're going there because of your coworker, and because you don't want to let them down. You don't want to burden them. So it's on that level in which we really get that energy to be able to continue to work with people. Fortunately, in our, at least in the mental health field, we have a pretty neat opportunity that, on an hour-by-hour, day-by-day basis, we get to see some really neat outcomes, and we get some energy from that. We know that we want a really good balance between work and personal life. So I've seen, I'm relatively new to the organization, but I've been a lot of other places, and I've noticed here in Pawnee, at least, that there is a big support for, if you need to go take care of something, you need time off, whatever it is, let's go do that. There's a lot of personal support, and that comes from top down and bottom up, and I think that's what keeps us going over time.
Okay, I'm going to exercise a little discretion here and make this a two-part question, actually. So you responded to the part about what your organization is doing and the culture. What can the community do to help you maintain staffing and employees and ensure that retention? Are there things that the community should be contributing to help with that?
For me?
Yeah,
Oh.
yeah, you can.
Oh.
So like I said, I'm using
I
a
don't
little
really know.
moderator discretion here. I'm going to give you a two-part
Yeah.
question.
We came to hear you talk.
Oh, I appreciate that. Yeah. Have a seat, everybody. Well, one of the things that I think really means a lot to us as providers, especially in mental health, we don't get the glamour jobs out there in the healthcare world, is that when we get feedback, if we've done a good job, if the family members, the parents of a child that comes in, if they feel like something good has happened, they let us know about that. we get to hear all the time about if we've done something wrong, of course. But we really love that, and it just feeds us. And that's what the community can do for us, is let us know what's working and what's working well. And that's what keeps us going. That's what gives us the energy.
Okay, perfect. So Tracy, so it's kind of a two-part question.
I caught that.
You just get it? Okay.
It was a trick.
And Bruce did a great job answering this. You know, we've been on a journey at Stormont, and you know, healthcare is a tough business, and you know, our providers went into healthcare to take care of patients. That's what they're driven to do, and so often in healthcare, you become burdened with administrative tasks, the electronic health record, the number of clicks that you have to do, the different checklists that you have, and it becomes overwhelming. And part of our goal is to take what we call friction out of the system and do what we can to bring our providers back to what it is that they went into healthcare to do, which is to be with the patient and get to spend more time with the patient. I believe that's what the patients want. They want to have that undivided attention. They want to be able to make a connection with their provider, and we want our providers to have that connection too. The additional burden of administrative tasks and things that just fill up the day, I think oftentimes contributes to the burnout, contributes to the stressors, and eventually it's that point where they look for alternatives and other places perhaps to go. If we can make working within our system and working for a community better, then the whole community benefits overall. As it relates to what the community can do, I would echo. We get to hear a lot of the bad stuff. We get to hear when we're not doing things right, and we want to hear that too. That's how we improve. That's how we take that information. We work with it to take actions. But just a simple compliment, a recognition of what we're doing right, those things can go a long way. We implemented a feedback, not just through a survey process, but what our patients can do just to give us feedback. We call it small moments, and it really does. It helps elevate the culture, it elevates the mood, it elevates just what the team can do overall. So encourage you to talk to your physician, talk to your provider, give them that feedback. That'd be great.
Okay. Chris?
I'll answer the second part first. Burnout is real, you know, in our industry, and you know, it's something that a lot of people don't want to talk about, and you appear weak and those kinds of things, but it's happening, and you know, healthcare is a tough business. Like Tracy said, it's emotional for everybody on both sides, the delivery and who's receiving the care. And but I would say thank your providers. You know, when they do a good job, let them know. You know, the small acts of kindness from some patients that, you know, I was in our cancer center the other day, Central Kansas Cancer Center, and a patient brought some stuffed animals that their loved one that passed away had collected and brought it to the staff to share with kids who were getting treatment for cancer. So those kinds of things that really touch the staff. And so those are the kind of things that patients, just the small acts of kindness and letting people know you appreciate them. But I would also say, you know, I'm lucky. I get to work with people who love what they do at Manhattan Surgical Hospital and all of our organizations. And you know, I hope that if someone's having burnout, that they know that they can go to Human Resources and that will help them and that sort of thing. But you know, we do things. We celebrate Hospital Week. We have a huge party every year for all of our staff. You know, we do things constantly. You know, I buy them lunch, breakfast, those kind of things. And it's just those small things that they appreciate. But we have the most outstanding staff, and you know, it's a joy to work with them. And I sure hope if any of them is suffering that they'll, you know, hopefully tell us and we can help them. So.
Okay, thank you. Bob?
So my crew at the hospital would tell you that I'm very down to earth, very tangible. And so we've tried to address this by doing stuff that's very concrete. I'll give you some examples. We've got some small areas, only 1, 2, or 3 staff that are in the department that do the service. And in the past, there might have been an expectation of 24/7 call. As you might imagine, that leads to a lot of turnover because people just can't do that. And so we actually made some tough decisions around limiting the hours that certain services would be provided. It's helped us retain the staff. It has meant, and I apologize if it's been an inconvenience for anybody in the community, but the reality is we actually still have the service. And it may be only 15 hours a day instead of 24, but we have it 15. And so I think it's sometimes just making very conscious, potentially unpopular, but just some very conscious decisions about how we're going to treat people and respect them and keep them whole. To Chris's point, the burnout deal is more than real. I think we've all seen in our careers folks who have left nursing. There's a study that was done just a few years ago. I think it is 60 or 80% of all physicians would make a different choice if they had to make it again. And so this is real. So you certainly have activities. We have a schedule actually that we're doing stuff with our folks because I always tell people, I tell them two things. One, what is it, guys? If you're still sleeping every night, then you're only working part-time, right? And that's kind of in jest, but that's sometimes the way the folks in our industry feel. But so you just got to take the time to appreciate it. And it's about building a culture of recognition and having people be appreciated. And so I think that, from the community standpoint, it is nice to hear the good things. It's also interesting what we learn when you tell us what we didn't do well. And so we're not asking you not to do that, because that's also important. A little balance is good. And, I also think that, I think to the scale. So we deliver about 1,100 babies a year here in Manhattan. We'll see about 3,400 inpatients that are non-OB. And so that's a bunch of lives that we touch. At the same time, our physician partners in town are having seen about 500,000 office visits. So there's all these touch points, all these opportunities, one, to give good service, but also to get feedback. And so I think, again, to Chris's point, I think as you said it, next time you're at the doctor's office, tell them, you got a great receptionist, you got a great nurse, or could you maybe do this differently next time? But the feedback is good. Sorry.
Deb.
I really don't have anything. These people are knocking it out of the park.
Okay, well, we're just going to go to you first from now on. That's fine. Josh.
Yeah, so to reiterate what everybody has said already, burnout is very real, and it's an issue that is prevalent in EMS. For those of you who don't know, the vast majority of EMS providers throughout the United States work 24-hour shifts. So they work 24 hours on and then they get 24 hours off, and they work some variation of that. It's no stretch of the imagination to imagine that can contribute to burnout. So at Riley County EMS, actually fairly recently, what we've done is we've adopted two pretty unique process changes that are unique to EMS, not only in the region but in the state. And the first is we have what's called a peer support program. And so that is by definition, that is a peer-to-peer kind of off-ramp, I would say, for when an individual is struggling with burnout or struggling with any issues in the workplace. It gives them a safe place to kind of go and access help and assistance and guidance from their peers, and even has the ability to kind of refer them elsewhere for additional guidance and assistance. And as a peer program, that has nothing to do with admin. So there's no fear of reprisal. There's none of those stigmas associated with, well, I'm weak, I should be able to tolerate these 24-hour shifts. So we've taken that away. It's a nice, safe off-ramp. And the other thing that we've done is we have changed policy and changed business, like daily shift structured duties, to allow for some safe and appropriate rest time during the day. It's important that our providers be just as well rested and compassionate and professional at 2 a.m. as it is at 2 p.m. And so now we don't force them to be awake and to be doing mundane duty tasks, which maybe historically we would, because we'd rather have them getting that rest so that they can be responsive to the community's needs in the early hours of the morning.
Okay, thank you. Okay, the next question, we'll start with Tracy. So we all know that the National Bio and Agro Defense Facility is in the process of being built here in Manhattan. And I think the targeted opening date is late 2020 sometime. And there's been a lot of assurances in the community that the kind of facility is that the community doesn't need to be concerned about an accidental or deliberate release of pathogens. But if there were, is your organization prepared, and prepared in what way, to respond to a need in the community?
Well, I think if anything like that were ever happen, it's going to take a community effort. Oh, I guess you can't hear me. I think if that were to ever happen, it will take a community effort, and it's not just going to be here in Riley County and Manhattan. Is this not working at all? Okay. Can you hear me? Yeah? Okay.
Really close.
Really close. There we go. What I started to say was, if something like that were to happen, it's going to take a community effort. Good news is that there's emergency services that are here locally, and all hospitals, and I venture to guess most of the healthcare organizations practice emergency preparedness and what it was going to take should we have a disaster, and we'd have to have those things initiated. We would work closely, obviously, with Christi, with Manhattan Surgical Hospital and others, and EMS, law enforcement, to provide the level of resources that we need, either here locally or through our emergency and trauma program up in Topeka at Stormont, Vail. It's something we drill consistently. We do community-wide initiatives, and those are things that we know we have to be prepared for should they ever happen.
I think so, yeah. I have a loud voice anyway. So yeah, everybody's talking about the zombie apocalypse is going to start in Manhattan, Kansas. You know, so that's like the big joke. But in case you guys missed it, NPR did a story on NBAF not too long ago, and you know, I've read a lot. Obviously, I moved here not quite a year and a half ago, and you know, love Manhattan. I graduated from K-State, and so obviously I would never want anything like this. None of us would. I mean, it'd be awful. But my understanding is that the first design, you know, that they put together, there was a substantial risk of some kind of release, but they went back and redesigned, and it's, you know, less than 0.5% or something like that anything could ever happen. And of course, what are those statistics based on? I'm not an expert on it. I'm just reading things and listening to the news reports. But I think we absolutely should take precautions and do some drills, you know, what if this happens. And I think because this is not just an outbreak of you know, something, it could be something very scary. So, I mean, we probably need to be looking at that and be doing drills together with the fire department and law enforcement and medicine and EMS and doing some type of drill to make sure that we're ready for something like that so we can contain it and minimize it and so forth. But I do understand. I mean, I think they've done everything they can to keep that facility safe and taken all the precautions and spent a lot of money, a lot of federal government money to build that building and make it safe. So it's not going to keep me up at night, but I do think it's very much worth doing the drills and being prepared.
Okay, thanks, Chris. Bob?
So actually, we are. I think we're definitely prepared already. We already have a level 3 lab in town. It's right down the street from the new NBAF. So that type of research has been going on in this community actually for a long time, and maybe people weren't aware of that, but it's been there for years. As far as the community drills, that's actually a requirement of all acute care hospitals in the country. We have to do the community drills every year, plus a bunch of other activities around emergency management. We actually have a community drill here in Manhattan in July, and we're waiting for the final date to potentially be one with Fort Riley during July as well, a community drill. So, and that involves all of our agencies, all the other resources, and it's all about, the biggest thing in any kind of event is the coordination and the collaboration. And you just have to practice that, quite honestly. It's not as simple as you might think. The work about 2 weeks ago around the potential flood from Tuttle is a good example of that. Emergency management established a command center, people from different agencies there. We actually had someone from the hospital there. Did any of us see a patient? No, but it was important for us to be there because it's a good practice for how you do these sorts of things as we go forward in the future. The needs around emergency management, I think that training is also real. One of the things we're going to be doing over the next 3 years, the Department of Homeland Security provides training to all first responders and healthcare providers in our country for free down at the old Fort McClellan in Anniston, Alabama. All of our leaders are going to be rotating through that week class to learn how to work with all these other agencies from all these other places. We had an incident actually just about a month ago, a health concern with a patient coming out of Pot County. And so what we did was connect with the CDC. Our infection prevention and quality folks are on the phone with the CDC while we work through the issue with the patient. Turns out, not an issue. But that's I mean, we practice this, and then also we're doing it live already. And so I guess I don't worry. I think there's, like as Chris has indicated, probably a little hype, needless hype. These facilities are built safe for a purpose and reason, and we've got to have some confidence in the folks that are operating them. So.
Dr. Dobeck.
The physicians in the community are working together and ready to handle the crisis.
2 microphones. I again agree and would just kind of reiterate what's been said by the others. I am confident in the individuals who are working within BAP and engineering and constructing that facility that the threat is mitigated. But as they also said, training and preparedness is the name of the game. And especially in our industry, it's the bread and butter of the majority of what we do. First we do routinely train, exercise, and drill on a variety of emergency type disasters and multi-agency cross-functional responses that would be required, participation for Riley County EMS. And that happens, almost monthly. And I think, it happens, not necessarily always in the public eye, but I think it's important to know that your first responding entities in Riley County are diligent in their preparation and in their ability to respond to any emergency. And I also, I was glad Bob brought it up. I think the silver lining in the potential flood was that. I think it really gave us a good opportunity to put all those pieces together, put all those agencies together in one room, and see that we have the ability to come out of our silos and to work together towards common goals. And I found it to be a successful period. Despite none of us interacting with any patients, I think that collaboration was there, and it was good to see that. And I think that collaboration is born out of the amount of training, and the amount of exercise, and the amount of drills that happen outside.
Bruce.
Okay, great. One of the neat things about working at the Pawnee Mental Health is we actually cover about 10 counties. Well, not about 10 counties, and with the 10 counties, there's I believe around 13 different hospitals that we work with. So these drills that they have at the hospitals that are required, we're there to participate, support those, even the ones on the Nebraska border. And it's really, really neat because it's not just what we're drilling about, whatever the mock disaster is, but the really neat thing is you're there and you're working with people, problem solving with people that you might not have an opportunity to otherwise. So the drills are really, really helpful that way. They don't necessarily have to be specific to MBATH or the zombie apocalypse or one of those things. I've started to take things a little more serious about the zombie apocalypse or the 1.5% sort of an issue. I moved here about 3 months ago, or no, I'm sorry, in October to work here, and I kept a home where I was living before, didn't sell it, and probably around 4 weeks ago, I guess it was, a tornado took the whole home. So, and that's at 0.5%. It'll never happen to me, right? So I don't know about the zombie apocalypse, but I'm stocking up on bottled water. Yeah.
Okay, thank you. The next question will start with Chris, and we got this question in various forms from 3 or 4 people. So I'm just gonna read them. a couple of them are scenarios, but anyway, the one question is, I'm very concerned about the cost of transfers to other medical centers because we lack the resources to address issues locally. What is the cost of helicopter transfers and ambulance transfers? Then related to that, how come so many cardiac and GI bleeds are being transferred out of the county at night and weekends? And then the other one related to this, a man 80 plus years old and living at Meadowlark falls and hits his head, is taken to the ER and seems to be okay, but it is recommended he stay overnight for observation. He's taken to Topeka. Why not stay here? A gentleman living at Scenic House has a bronchial problem and needs to be hospitalized. He is taken to Salina. Why? So I guess think about those questions in terms of what that means if you're a physician, if you're a doctor, what that means for your patients, and then also for the facilities providing care. Chris, you get to start.
Well, I think, that question, I think the core of that problem is staffing and resources in the healthcare system. I know that, physicians in the community, as Bob said, they're predominantly independent physicians in this community. So they're running their own businesses, their own clinics, and they want to take care of patients. That's what they do. And, so when a patient has to be transferred, when we could have done surgery locally, not only does the hospital lose the revenue and the patient is inconvenienced, and possibly there's additional risk in the care process and all of those things, but the physician doesn't get to do that case and loses that revenue. So there's lots of people who lose when those transfers happen, and we definitely want to see people taken care of in Manhattan. We do provide emergency services, but that's not our focus. We do that. We transfer patients. We would transfer patients next door because we don't have an ICU. But as a hospital, we're required to have an ER, and we do provide that service when we have to. But I think it's seated definitely in not having enough staff because there are beds, I believe, in the hospital, and obviously Bob's better to answer this question, but we want to take care of patients in Manhattan. Our organization wants to see that, our physicians want to see that, and I think the patients want to be taken care of in Manhattan. So we're getting to work on the health professions and developing health professions in Manhattan, and more training, more nurses. K-State's getting involved with starting a PA program and possibly a nursing program. So there's a number of things that are happening, but I'll let Bob take it from there.
Okay, thank you. Bob?
So maybe, in fact, let me use the month of May as an example. I believe there were 56 patients transferred from Manhattan out of our emergency room to facilities elsewhere. 11 of those were due to there wasn't a place for them to lay down at our hospital. 9 of the 11 was because they needed an ICU bed and our ICU was already full. The other 2, and just to Chris's point, obviously workforce staffing is behind all of this because that's what creates your capacity. So the other 2 were on days where we didn't have enough staff to safely care for those patients. And I would guess, not knowing the exact dates when the examples you talked about, so you'd say, so what about the other 45, right? Because those were transferred out because it was a service that either was unavailable in our community or we don't do in our community. In May, and I think this was a little abnormal, but over 10% of the transfers were because of a patient with a brain mass or metastasis in the brain. So we don't have neurosurgery here. There's certain needs that they would have. 2 of the 6 were pediatric. And so we don't have pediatric subspecialists to deal with something like that, not only in our county, but quite honestly in our region. They most likely ended up at Children's Mercy or KU, something like that. Again, depending on what their specific need was. They could have potentially gone to Stormont too, again, depending on their need. So areas like GI, so we currently have 2 GI physicians in the community. The medical staff bylaws require them to take 8 days of call a month. So the requirement would be covering for 16, right? The physicians typically voluntarily pick up additional days of call in the specialties where we don't have at least 4. So you'll see that with nephrology, neurology, in the past with cardiology, certainly with GI. So they'll voluntarily pick up additional days of call, but that doesn't necessarily cover you for all 28, 30, or 31. And so if a patient comes in on one of those days and there's not a physician, it's the safe and it is the right thing to do to transfer them to a different level of care or a different facility. You know, it's kind of interesting. So at the same time that we're transferring out 56 patients, we were actually taking transfers. Because we're taking transfers from the smaller hospitals like the Clay Centers, the Council Groves, Geary Community, etc. To Chris's point, you know, periodically we take a transfer from Manhattan Surgical Hospital. So you have folks coming both in that are staying with us. Some of the ones who come in actually are also transferred out because of a specific clinical need they have or higher level of care need. So that's why it's difficult to answer to the question. I mean, workforce is a big deal. There's no question. Workforce is the underpinning of all of this. But in most months, we would move 30 to 45 patients out of the community because it's a service we don't provide. And I'm sorry, I'm going to keep going. Well, no, because it's actually, it's a great.
You can have my spot.
I'm always looking for that part where he's going to take a little bit of a breath so I can say thank you.
No, this is important.
No, it
No, I
is.
think-
I get it.
Well, no, I mean, I think again, it's just the reality. About 2 years ago, we had a vascular surgeon who reached out to us to say, is there a potential for me to have a practice in Manhattan? So I actually went and talked to some of our other surgeons, and the answer is no, and it's not because we're not nice people or it's not a great community. We don't have enough people here. You need 150 to 200,000 people to support one vascular surgeon, which also means they're only going to be on call 8 days a month. So you actually need more than that to support two. And so that is what has driven some of the shortages, if you will, or the small numbers of some of the specialties. GI, we actually have a hometown girl who's coming home. And so Dr. Disbrow will be here starting practice late July, early August as our third GI physician. We now have a guaranteed 24 days of call. And if everybody picks up a couple extra, her maiden name was Lindquist. You guys probably know. Some of you probably watched her grow up here. And so that's, again, it's a recruiting success story, but also it fills a gap. And that's, I mean, I think that's the challenge. Quite honestly, that's what drives a lot of the transfers, if you will, are we do have gaps. And a piece of that's population-based that, and for the foreseeable future, our population is not going to double or triple. And that is why we rely on folks in Topeka, and we rely on folks in Kansas City. You know, I think everybody's aware our system, you know, we're statewide, our large hospitals are in Wichita. We rarely transfer patients there because it's a longer either flight or drive. And the, you know, doctor told me years ago, different state, that medical care follows the rivers. Because it follows trade patterns. And that's true here. It flows to the east, at least in our part of the state. It flows east. And so that's, you've got to have relationships, partnerships, whatever you want to call it, downstream if we want to be able to hand these folks off efficiently and nicely and correctly. And so, I mean, understand the sensitivity around the patient transfers. We certainly get that. For us, you know, to Chris's point, it's a loss of business. We're all in business in the end, so that's not something we're looking to do. But if it's either the right thing for the patient or the safer thing for the patient, it is what we are going to do because that's what's right for that patient.
Thank you, Mr.
Sorry.
Bobble. Yeah.
And sorry for using Deb's time. And probably Josh's time too.
I'll be very brief. I think the only comment I have is that our role in the questions made there is to simply facilitate those transfers in a safe and clinically appropriate way, while also balancing our duty to maintain a posture of readiness for 911 calls in Riley County. And we have noticed an increase in inter-facility transfers over the last 2 years, and I think that is one that as an agency I'm confident we've been responsive to, and we work diligently with the staff in the ED to make sure that we can time those transfers in a way that's mutually appropriate for both entities, to maintain that posture of readiness while also facilitating that transfer and getting those individuals to that definitive care that they require.
Bruce, do you have anything to add?
A little bit.
Sure.
Yeah, If you were anywhere in the 10-county area that we serve, if you needed more than outpatient services, you're going to be transferred, as it stands right now. And your options are Topeka, Salina, Kansas City. If they're little children, we're talking about Kansas City, Missouri. We go to the Nebraska border. We're also butting our head against a wall of capacity. The places are oftentimes full. Psychiatric inpatient care just is not a moneymaker. It's actually a money loser for most medical surgical hospitals. It's kind of a necessary evil, they consider it. So it's not an attractive service to expand and grow and invest in. So you're not going to see that continue to grow. So the capacity out there just isn't very much. So we have, and I see this firsthand, I work with the emergency room over here at Via Christi all the time during the daytime over there seeing folks. I see firsthand people sitting in the emergency room, psychiatric emergency. It's the wrong place for them. They're not getting the care that they need. It's horrible for them. And the staff, they're not used to that. They want to see gunshot wounds and car wrecks and all the glamorous stuff. You know, they want to see the sexy stuff. They don't want to see a mental health issue. So it doesn't really fit within their realm. So it's a difficult spot for them to be in as well. And we might have that person sitting in that room for sometimes days on end, waiting for a bed to open up someplace else. For days. And that's taking up beds in the emergency room. They'll also take up beds in the intensive care unit, the wrong place for a psychiatric patient that needs more than that, more than just sitting in a, they don't need a bed and be a horizontal patient. These are vertical patients. Our transportation service, we don't use medical transport for them. None of our hospitals do. Instead, we have, in this whole area, we have one service. It's a little retired couple who has a vehicle, who drives around. They transport people to and from everywhere from the Kansas City area to way out here to Salina. It can take hours for them to get there. They don't like to drive after dark. So if it's past 9 or 10 o'clock at night, guess what? The patient's staying in the emergency room till the next day. It's horrible. That's the reason why the emphasis behind the crisis stabilization unit here in town is to provide relief for that and provide the service here in town and get close enough to home.
Okay, thank you. Tracy?
Yeah, I'll have to use your mic. We'll share. I'm just going to add a couple of thoughts, and Bob covered this really well. You know, oftentimes Stormont Vail is the transferring hospital, and we have the same challenges. We have staffing challenges. We cover predominantly all the specialties, but there are things that we even have to transfer out. When we do receive a patient coming from any of the communities outside of Topeka, our goal is to return that patient back to their home as quickly as possible. We want to provide the right level of care, the right services. We want to make it as seamless as possible with the transfers as we can. And when they are at our hospital and they're under our care, and when you're from out of town, it's a tough place. You're in a very vulnerable position. We want to do our best for the families, for the patients, and be able to return them as quickly as we can to the home and to their primary care physician or their primary provider. Those are important things that we look at, and because we have the opportunity to have our physicians in the emergency department at Via Christi, it does give us an opportunity to have a very seamless, I would say, approach to the transfers when we do have to do those. But again, a lot of the challenges we have are staffing, particularly critical care and nursing, and it is always of interest, and we're very excited to hear what K-State is doing, both with the physician assistant program and hopefully with the nursing program. That'll just bring additional resources to the whole community and to the state, so it's good news.
Okay, thank you.
Yep.
Okay, we're actually on question number 5, and this question is, talk to us about what your organization does in terms of addressing the needs of the uninsured and underinsured in the community. Talk to us about the charitable care that your organization provides. And Bob, we'll start with you. And referring everybody to Susan doesn't work, so Susan can't do it all.
So the reality is that folks without insurance come for all services, and so it can be a surgery, delivering a baby, needing a lab test, needing an x-ray. As I think I alluded earlier, so we've seen our charity care double just in the last year. To give you a scale of that, through the first 11 months, it went from about $6.5 million to over 13. And in addition to that, about $4.5 million that we wrote off to what we call bad debt. And I would say this, in my layman's terms, these are people who have the ability to pay but choose not to. That actually is stable. So that's interesting to me. It's not good if you're trying to run a hospital, but at least it's stable. Part of our mission statement is to care for the poor and the vulnerable. And so for us, it shows up in a bunch of different ways. We run an outpatient behavioral clinic in town. We run an outpatient diabetes clinic in town. We have a wound clinic. We do lots of things that, quite honestly, don't make a lot of money, but they're providing some very needed services in the community. We're 1 week away from opening up a new cardiac rehab gym. And I've actually been questioned by people, and even within my own organization, saying, why are you doing that? Why are we spending all of this money? And the reason is that downstream we'll have fewer heart failure patients get readmitted. And so we opened actually in cardiac rehab, the staff opened up what's called a phase 3 program about 6 months ago. So if you're a patient, you're either in phase 1 or phase 2, depending on your progression. By the time you're phase 3, you're back to being a citizen. And this is a way to encourage people to continue cardiac rehab, even though they no longer maybe clinically need it, but in many cases, they still need it, and they need the supervision of a nurse while they're exercising. So I think it shows up in a bunch of different ways, Deb. We write off a lot of care. That's just part of what we do. There's a piece of that, of course, that everybody else is helping. That's what all the rest of our insurance premiums are helping cover too. But I think the troubling thing for me is if it went up that sharply, that tells me that we will have to wait and see.
Okay, thank you. Dr. Dobek.
So, Deb, my organization consists of 110 physicians of all specialties in Riley County, and I would bet to wager of those 110 physicians that over 100 do volunteer work to help the vulnerable and uninsured and help them with social determinants of health. I'm looking at the physicians in the crowd here, and I know that all of them volunteer for Susan's organization, for their churches to take blood pressure. Karen Hawes fixes their bicycles so they can ride around town and get their health care. I have stepped up just this week, and I am going to be volunteering free of charge to take care of the sex-trafficked women in our community with Deb Klutz, and that is, I just looked this up today, that is a $40 billion industry. I look at that number and I can't believe that. So that's what I want to say. We're trying to do our part.
Thank you. Josh.
I think, first of all, EMS operates at a net loss and by virtue of a tax subsidy. The services we provide are acute and critical and enough in nature that there's no deviation in standards based on insurance or reimbursement potentials. So I think, so what we maybe do is in my experience, financial hardship is one of the most prevalent barriers to wellness, not only in Riley County but in anywhere I've worked. I mean, we see these people routinely in their homes, having a rough day, calling 911, needing help, who in that moment, in one of their most vulnerable, unwell moments, are concerned about their ability to pay the bill. And I think that's terribly unfortunate. And so, we certainly, along with everybody up here, advocate for Medicaid expansion and for increased access through both cost savings and cost avoidance, and we hope to continue to be a part of that.
Bruce.
Great. Well, with community mental health, it's part of the nature of what we do, that a lot of the folks that we see don't have the resources that would normally be available to pay for what they actually need. So we do go for state funding, and the counties provide funding for that as well. And we barely squeak by every year, but we cut where we can to be as smart as we can with what we're doing. One of the things I think that when we talk about uninsured and the Medicaid we have the Medicaid population, commercial insurance, but then of commercial insurance, there's a large portion of that in which we say, oh, I went and got my health insurance plan. Well, what a lot of people aren't realizing when they're self-purchasing their health insurance plans is what they've got is something that has about a $5,000 deductible in many cases. What we're faced with then is, because let's say for example they bought a Blue Cross policy. It's got a $5,000 deductible. Well, that's a lot of money for them to come in to see the physician and counseling and all the other services that are out there. So let's base it on their income and give them a sliding scale. Can't do that. Contractually, because we're contracted with Blue Cross, for example, to provide those services, we have to charge the Blue Cross rates. So now we're bound to charge these particular rates because of a high deductible plan, and we can't even give them a discount when we want to. Now, granted, we don't have people going around and knocking on doors and, Guido out there collecting, the co-pays and deductibles and things. So we get by that way. But that's a big void, I think, that a lot of people don't understand when they say how many are uninsured. Well, how many of those, what's the deductible is what I would like to know. Yeah.
Okay, thank you. Tracy?
Well, the affordability of healthcare continues to be a challenge for all of us, and I agree. It's access to. I'm going to try to get this closer. We continue to see rise in high deductible health plans, the ability just to pay, and if that's a barrier for access to services, then people are prolonging getting to see a doctor or getting the services that they need. As a system, we serve a 13-county area, Riley County being one of those, and we do about $43 million every year in charity care. We also have a number of our providers that are doing outreach and volunteering to provide for their patients. And you asked the earlier question about burnout. Well, these are the same providers that are spending the extra hours and the extra time with their patients out in the community, at the grocery store, connecting with them at a ball game, doing things to really ensure that they're addressing some of their needs. We've also been looking at ways that we can get to where the patients are and doing connecting with patients in different settings. Could be at a church, at the high schools, because that's often a place where you can connect and you can address healthcare needs and not necessarily have to do so in a clinic setting or at a hospital. But sometimes it's not as intimidating, and it's a way that we can ensure that we're getting access to those individuals and that they're feeling like they're getting the care, or at least connecting with the provider in a way that's positive.
Chris?
Well, I think everybody did a good job of talking about it. We, in our facilities, our Blue River Family Medicine, our family practice, as well as Central Kansas Cancer Center and the Manhattan Surgical Hospital, we do accept Medicaid. And then also, as everybody's talked about, the larger deductibles, I mean, patients are being more and more responsible for large amounts of money. And you have to be creative. And, if that's one thing I would say to everybody, get the word out. We will work with people. I mean, we do have the capacity to put together payment plans and to help people through that. It's not, a no, well, we're just not going to do that procedure. We try to figure out a way to help people and get them on a payment plan that they can afford. And, so there are resources and things that are out there. I had a phone call today from a marketing person who was marketing a plan like that. It's called MediPlan or something like that. But it helps people finance, healthcare deductibles specifically. So, I think we're going to see more and more of that. More of those types of plans are going to be out there, and people are going to be, shopping and wanting to know what's the price of my care, what's the total going to be, and sometimes that's difficult. But we'll work with you. We will we will figure that out. I mean, if someone asks, how much am I going to be charged? What am I going to be responsible for? We work really hard to try to figure that out. We can't always say definitively because sometimes the care changes throughout the process, but we'll do everything we can so you understand what it's going to cost you and what you might be responsible for at the end of the care. So we want people to be informed up front. We want to be flexible with them and make sure they know all the resources that are out there, and that will help you finance that plan or that responsibility many times. So.
Okay, thank you. I think now we will start with closing remarks, and it's wide open for you. You can touch on something that we haven't touched on, or you can go back and revisit something that you've touched on before. That you have 2 minutes for a closing statement. And Bob, start with you.
Should I let Deb go first one?
It's however you guys can work it out down there. That's fine. I'm okay.
Thank you. I just want to thank you all for coming out tonight. I had no idea how many people were going to be here, what we were going to talk about, and I just want to thank you for being here, and you who are watching in for being engaged and caring about this community and caring about the people in this community. And thank your doctor.
Yeah, sure, go ahead.
Sure. You know, so actually, Deb, ever since you reached out, which is over a month ago now, I've been thinking about the title of tonight, which was something effective as Riley County at a healthcare crossroads. And so quite honestly, we've been going through intersections for the last bunch of years. And that's all I see ahead, actually, are a bunch of intersections and crossroads, if you will. Yeah. Are there things that can be done? I think part of it is you got to take a community pause. I think we got to really listen to what Bruce has been saying. One of the biggest deficits we have in our community, in our region, in our country, quite honestly, is around behavioral health. And it's not simple, and there's actually multiple populations within that. And so I think, and that's the complexity of that is part of the difficulty in that, and the lack of resources. Are you going to put your money into child adolescent, or are you going to put it in geriatric care? Are you going to put it into adult, or are you going to put it into substance abuse? I mean, there's all of these things around behavioral that I think are huge. That last question, I think, again, just resonates with me around, so what are we doing? And so I think, again, of the tangible. So we made a decision over the last 4 years at our hospital. We've only raised inpatient prices one time in 4 years. Because we know that affordability is a key issue. And if you're in our business, you also know that what we actually charge isn't really what you pay, which is kind of to Chris's point. So healthcare is probably the only business in the world that everything is discounted by someone, somewhere, somehow. And so that's why you sometimes just have to ask and have it explained to you. And the technology around that is actually much better now too. We really can estimate better for people what things are going to cost, even at a level of complexity. But it takes some time. You got to sit down and you got to, again, to Chris's point, you got to have to really work through that to really understand what might happen, what might not happen, who else involved, all the other players. If you come into the hospital, you're probably going to get at least 6 bills, depending on what your needs were, because all these other providers are going to be billing you too in addition to the hospital. It's the pathologist for reading this, the radiologist for reading this, you're from your surgeon, from anesthesia. I mean, it just kind of goes on. And the general public, for us, we just like, sure, that's how it works. It's not, I think we're probably coming to a little bit better understanding that it's difficult for the rest of the world to understand how things work within our industry. And the healthcare finance, by the way, is messed up. There's no question. It's going to take somebody else probably getting elected to change that, just because it's a very process-oriented deal. And there's just so many things that have to be kind of worked through to get there. I would second Deb's appreciation, one, for being asked, and it's great to have an opportunity to kind of talk about this as a group even, but certainly appreciate all of your interest in the fact that you show up and that you care enough to be here. So we appreciate that.
Okay. Josh, closing statement.
Yeah, so as I was leaving the house this evening to come to the event, my 3-year-old, his name's Jackson, came up and he said, like, cool shirt, where are you going? I agreed, it's a cool shirt. And so I said, I'm going to a community town hall. And that's a wacky concept for a 32-year-old, much less a 3-year-old. And so he said, well, what is that? And I said, well, we're a group of people, gather together in a room to talk about what's going on. And so he said, kind of like circle time at daycare. Said, absolutely. Very keen observation. So gave him a hug, told him I loved him, and as I was walking out the door, he said, don't forget to sit crisscross applesauce so you can hear your friends. And I thought, how profound. I thought about that the way over here, actually. And so I think there's value in what we're doing today. And I think it's important that these dialogues continue and that the community articulate their needs and their concerns, and that the people involved in healthcare hear them. And I think people who know me have heard me say one of the things I like most about Riley County is it's too big to be little, and too little to be big. So we're big enough that we're blessed with resources that some smaller communities find sparse. But we're also small enough to not be overburdened by a cumbersome bureaucracy. So I think this is a community that if we can find ways to come out of our silos and have discussions like this, that we can make lasting and significant change.
Great. And I'm wondering, circle time, do we get snacks?
If you bring it.
I need apple juice, just saying. One of the things I wanted to comment, an observation, I've been working in the mental health field now for almost 30 years or so. And I haven't seen a community in the interest in the generation of some of the focus of some of the things that I've had the opportunity to be able to witness, at least here in this community. And that's a lot said. It's usually, mental health stuff is usually the dark thing you don't talk about, and it wasn't out there. And that means a lot. And the overall wellness of the community as well, and the community action. So I encourage you to, I recognize and respect the passion, the interest that the community has, and I just want to encourage you as much as I can to have that continue and let us know what the needs are, ongoing communication back and forth, and all the different facilities and things working together. It's been really awesome, so I've appreciated being able to see that here, and I'm honored by seeing that. Thanks.
I'm just going to first start by saying thank you again for letting us be here and for this conversation. And I think that I echo the encouraging attendance and the care that you all have to be here to listen to what we have to say, but also to ask your questions, because that's how you move things forward. And the strength of a healthcare system and all the providers and all the organizations that work together really do drive change. And the impressive starting point here is that Riley is a healthy county, and there's a lot of positive things that are going on. And when you can focus on those small few and put the resources behind it, I think that's where you can really start to see a change. One, in representing Stormont, Vail, but also our Cotton O'Neill providers, they do amazing work in this community every single day. Very proud of them, very proud of the fact that we can be here, and looking forward to the partnerships and the continued work that we can do to support you all moving forward.
So I would echo all that. I think everybody's done a really nice job kind of summarizing things, but what I would add is, as we look at what those opportunities are, let's focus, let's make some decisions about what are the things we really want to do. I know one of the goals is to make this a better community to retire in, and that's all about having a good healthcare system, a strong healthcare system. So if we want to achieve that, we really have to focus and set some tangible goals, some things we can measure. Let's go get some things done. You've seen what some of these folks up here and then others in the community have done with primary care, and I think that's much better. So that's a success story. But the last thing I would say, it's sort of echoing, but we have a lot to be proud of. I mean, I moved back to Kansas, and I moved back here to work with our investor physicians and a medical staff at our hospital and a staff at our hospital that I think is outstanding. I think we have a lot of outstanding providers in this community, physicians, nurses, mental health providers. So we're really blessed with a lot of good resources in this community. So I guess my thing I'll say is don't walk away from here hanging your head. We are 5th in the state. We have some things to work on, and like I said, we need to pick some things and really focus on some things. But we have a lot to be proud of, and this is a great community with a great medical community. And so it's just how do we take it to the next level? And I think some of the things, the health professions thing, we're starting to talk about already. There's some cooperation with Manhattan Area Technical College and via Christi and the surgical hospital and others, to come together to look at the shortage of nurses and other professionals. So there is some activity, and the chamber's involved in that. So there is some activity in those types of areas. So we need to continue to work together, but I don't want anybody to leave here with their head hanging, because I think you have a lot to be proud of. And I've been impressed with the medical community and the skill and dedication and what's already here in Manhattan. So let's get it together and take it to the next level.
Okay, please join me in thanking our panel members. So if you didn't do it when you came in and you are interested, there are sign-up sheets, and you can leave your name and email address. And if you, as Jennifer said earlier, if you're interested in being involved with the Flint Hills Wellness Coalition, we meet on the 2nd Thursday of each month from 12 to 1 at the health department. We'd love to have you join us. We do things, so that's good. So we don't just sit and talk. We actually try to get some things done. So, and I'm sure the panel members would be happy to chat with you for a little bit before they leave tonight. So thank you all very much for coming.
It's private.
Hi, John.